where you can, forget a couple of things from the exam point of view. But in this chapter, I don't see anything that you can, just skip, because everything and, almost all the things are potential parts of long question as well as short notes. So we will start with disease prevention and control. And you know most of these things when we discussed uh, the previous day, or maybe the day previous to that, the chain of transmission. It's almost the same thing. But then we will arrive at a national immunization schedule, which I'll take some time. And then, of course, we will go to emporiatrics and finally end the chapter with investigation of an epidemic. Please recall, we started with the definition of epidemiology. We described the tools of epidemiology. We also said what is the classification of epidemiological studies. Okay, that table is very important because it may come as a part of the question. You may be asked to describe a descriptive study, a case-controlled study, or a cohort study, and rarely a RCT, which is very much in the news now, as I told you, because of the last year's Nobel Prize in Economics. After that, the most important things came, like disease transmission, chain of transmission, where we had various definitions. Then we described, again, under infectious diseases epidemiology, various other definitions. If I can recall, something like eradication, elimination, exotic disease, sporadic disease, what is an endemic, what is a pandemic. Right now we are in a pandemic. What is a hyper-endemic situation? What is holo-endemic situation? Please recall all these things. What is a zoonosis? You have already covered a lot of zoonosis. Zoonosis sometimes comes as long question. Then we came on to the cold chain last time, and we said how important it is. In between, we described the shake test for vaccines, which may be accidentally frozen, and you need to do the shake test before you again take a decision of using them or not using them. We also described the vaccine vial monitor and the open vial policy. All these are very, very important for you in pediatrics, some of the things in gynae, even medicine, and of course in community medicine. Okay, when you take the next step of becoming a PG, you will find all these things coming back and hitting you. And if you have done your MBBS well, I'm sure you will remember those things. So without going further into the revision part of it, we will go into disease prevention and control. Now this gets stuck up. Yeah, disease results from interaction of agent, host, and environment. Yeah. These we covered last time. Yeah. The effective control of a disease requires recognition of its multifactorial causation. That was chapter 2. I told you the various theories of disease causation, very important even from the exam point of view. The measures for controlling disease are classified as controlling the source, the reservoir, source or the reservoir. Both are not the same. Blocking the channels of transmission, protecting the susceptible population. The aim of disease control is to attack simultaneously as many vulnerable points as possible in the now familiar chain of transmission. Okay, controlling the reservoir. I won't go into a revision thing because we will then not be able to finish this chapter. You all know what's a reservoir by now. You all know it can be a case or a carrier. What is a subclinical or a clinical infection? In case you've forgotten the exact definitions, go back after the class and just revise them. Subclinical, asymptomatic, or inapparent. All these terms have come back to hit human race during the COVID pandemic. Then we have clinical cases which are mild or severe. You know how a severe case of COVID can even expire or die. Then we have typical and atypical presentations. The first link and the weakest link in the chain of causation is the reservoir, right? And elimination is easy with animal reservoirs, but very difficult with humans. And what are the steps in elimination or reduction of the disease possibility in humans? Early diagnosis, of course. If you come to the doctor early, if you are where you should be able to diagnose your disease early. Notification. Many of you have heard this term. I'll describe it and define it just after a few minutes. Epidemiological investigations, that's the last part of this chapter. Very, very important question. And for you to remember all the 10 steps all through your life, because many of you will be asked to do some kind of investigations during an outbreak. Isolation, treatment, quarantine, surveillance, and disinfection. These are familiar sounding words, but each of them you have to define. And with that, I can add things like lockdown. All these things are now the new terms which are coming up. I never thought of or heard of lockdown when I was a student. Rather, I didn't hear of it last year also. Okay, so these are the new terms which you may be given in the exam. So early diagnosis, we all know. I need not go into details. We have to do a rapid identification of the disease. The prompt identification will help stamp out the spark rather than calling the fire brigade to put out the fire. We all know the proverb, a stitch in time saves 9. Notification. Once a communicable disease is detected, it is supposed to be notified to the local health authority. When you are not well, you notify your teacher, sir, I'm not coming. When you are not coming to a friend's house because of some other preoccupation, you say, I can't join your party. You inform. So notifiable disease is defined as any disease for which an official report is required. Please remember that there are formats for this, and mostly it is for communicable diseases, but developed countries have even made notification compulsory for lifestyle or non-communicable diseases. Now, International Health Regulations 1969 amended 2005 covers 3 diseases which are supposed to be notified internationally. Yellow fever, India is free of that. Cholera and plague, both are rare now. So probably in the revision, these things will also be taken away in due course of time, but still they are there. In addition to the above, 7 diseases are in the surveillance list of WHO, which are louse-borne typhus fever, relapsing fever, influenza, paralytic polio, malaria, viral influenza A. See, influenza comes twice. I think it's a repeat. So it's not viral influenza A, it is viral influenza, SARS, smallpox. Okay, it should be viral hepatitis A. It is not viral influenza A. That is a typo. So louse-borne typhus fever, relapsing fever, viral influenza, paralytic polio, malaria, viral hepatitis A, SARS, smallpox is of course gone. It is eradicated. So 7 diseases stop at SARS. Other diseases watched closely are dengue, hemorrhagic fever, and tuberculosis. In India, tuberculosis has been also made a notifiable disease. This may be a question in your Viva. Please name some notifiable diseases. What is notification? This is a chart showing how things have been notified over the years and how they have been pooled. How many cases, what is the average, all that. Isolation. I need not go into details of this also, because most of you know what is isolation. You have learned about it, experienced it, faced it from the family and friends, and it means separation for the period of communicability of infected persons or animals. Please remember, infected persons or animals. When I isolate myself, I will be having some infection. COVID patients, when they are mild cases, they self-isolate. Okay, these are words which we now know, which have been ingrained into our brain. Infected persons or animals from others, and in such places and such conditions as to prevent or limit the direct or indirect transmission. We all know. The rest of the sentences you can make, but you must include it is separation for the period of communicability of any disease, especially a communicable disease of infected persons or animals. Therefore, it's a method of preventing transfer of infection from reservoir to the susceptible hosts. Ladies and gentlemen, we are now trying to prevent a disease by various means in the reservoir. For those of you joining now, I repeated this. There are many types of isolation, depending on the mode of spread and severity. Standard, strict, protective, high security, and now self-isolation. I just mentioned it. There are isolation wards in the hospital where you call it hospital isolation. Sometimes isolation may be difficult in a small household or in an overcrowded rural household, even in an urban slum. There is a special type of isolation called as ring immunization. Remember, infected persons are encircled with a barrier of immune persons through whom the infection is unable to spread. This was what was done during smallpox eradication. The health workers, they formed a ring of immune persons around people who could be infected or who were infected. This is called a special type of isolation called as ring immunization and not isolation. This is not herd immunity. Duration of isolation determined by the period of communicability, I already told you, and effect of chemotherapy. Where is isolation useful? Number one should be COVID. In diseases like cholera, diphtheria, streptococcus, respiratory diseases, COVID. Not very useful in diseases like polio, hepatitis A, typhoid fever, the intestinal diseases. Futile in cases of mumps, leprosy, and tuberculosis. Okay, of course, in an open case of TB, you can isolate the patient. Now recommended only when risk of transmission of cases is exceptionally serious. Boys and girls, the present pandemic is exceptionally serious. Treatment. We all know what is treatment. It is to kill or eliminate the infectious agent. I will not read other than that. There are individual or mass treatments. I'm talking about filaria. I'm talking about certain diseases which may have been covered in the communicable diseases chapter for you. So another process of stoppage of disease transmission and prevention is treatment. Quarantine. Well, what can I say about this? All of you have repeated this word hundreds of times since the time we all are under this pandemic. Limitation of movements of the freedom of movement of well persons. Please remember the difference between isolation and quarantine. Limitation of freedom of movement of well, that is not sick persons or domestic animals who may be exposed to communicable disease for a period of time not longer than the usual incubation period of disease, in such a manner to prevent effective contact with those not so exposed. Please remember the subtle difference in the definitions of isolation and quarantine, also applied by health authorities to a ship, an aircraft, or a train, or even any other vehicle or containers to prevent spread of disease. You see, during lockdown, the police people stopped the trucks from coming in from some other states or crossing the border. Why? Because there could be potential carriers. They could be having things which could be potential carriers of the disease. This is one kind of quarantine. Okay? It may be absolute. It could be modified. It can be segregation. That is for special consideration. So all these are types of quarantine. Modified is partial. Absolute is total strict quarantine. Segregation is of a group of persons from the others to facilitate control of disease. Particularly important in respect of international travelers. Please recall, when COVID started, we first restricted or we first asked the history of travel to a person who was struck with COVID. Okay? This quarantine had become isolated till God taught us a lesson in the form of COVID. We again got back this term, revised it, mouthed it, kept on saying it, and for all you know, you people may get a short note on quarantine. This is a photograph of the Hoffman Island in Lower New York Bay Area, which was famously quarantined because of cholera. See the kind of wall or the barrier created and the people there. And these are the health authorities who have debarred them from coming out. So it's a kind of lockdown, you can say. It's a kind of strict quarantine. Please revise your terminologies, especially with reference to COVID. You may get a couple of them in your exams. Quarantine, contagious disease, this is the kind of notice which was struck during the 1918 plague, I think. Okay, anyone violating this regulation will be fined not less than $10. Imagine, $10 those days used to be like today's, thousands. Epidemiological surveillance. I have already described the word surveillance and monitoring in the previous chapter, that is health. So I'll just revise the definition. The systematic collection, analysis, and dissemination of health data for the planning, implementation, and evaluation of public health programs is what is epidemiological surveillance. Please mug it up. Surveillance is watching over. It's a continuous, dynamic thing. We cannot say today Hyderabad is reeling under COVID. We have to watch for a few days, 14 days, 7 days, 1 month, and then say, well, we have done a surveillance, we have collected data, we have analyzed the data, and we have compared the data with previous data, and we can say that, well, there are a lot of COVID cases in Hyderabad and a lot needs to be done. Earlier, it was confined to restrictions being placed on individuals after being in contact with an infectious disease person. But now it is no more like that. So please remember one more term, surveillance. Then we have disinfection. I will try and tell you about disinfection. I'm sure disinfection and sterilization have been covered for you in the clinical postings in your third semester. Please go back to your notes, or some of you who have not taken notes, please try and scratch your brain and try and find from your memory. This has been covered. But still, disinfection should be done for all secretions and excretions of a patient and articles, that is fomites, contaminated by the patient. That is another method of stoppage of the reservoir from spreading the infection. There are two types, concurrent and terminal. Concurrent is immediate destruction of infectious material throughout the course of illness of a person. I am ill, I spit. The spit is taken and disinfected. I am ill, I pass loose motion. That loose motion is immediately disinfected. Terminal disinfection happens at the end. That is when the patient is discharged or unfortunately he dies. Terminal disinfection takes place of the whole room, the furniture, and all other things. In the case of COVID, whenever we have a patient in the hospital, we fumigate it with formaldehyde. And remember, that is what is terminal disinfection after the patient leaves. The room, the furniture, all things, the mattresses, the pillow, everything is exposed to infection and they are disinfected. I gave you the example of formalin. Interruption of transmission, that is the second part. The first part is control of the reservoir. Now, this is the chain which we all know. I have told you, I have given you this chain before. Now we have to break this chain. Changing some components of a man's environment to prevent infectious agent from patient or carrier entering a susceptible host is what is interruption of the transmission, that is breaking the chain of transmission. Now, what are the examples? Treatment of water with chlorine, improving standards of sanitation hygiene, vector control measures, anti-larval, anti-adult, self-protection measures. Diseases spread by droplet infection are difficult to control. Therefore, we have to wear masks. Whenever we cough, we have to put our elbow against our mouth and then cough. Whenever we open the door, we don't hold it by hand, the doorknob, but we shove it with our shoulders or elbows. Okay? So these are the various methods that interrupt the transmission. And what are the other methods of increasing our host resistance? That is, you should be now more immune. Get plenty of sleep, exercise, eat right, have regular checkups. You people are semi-doctors, or you can say half doctors. You know how to, do your own, perhaps medical immunizations. You should have your immunization, status very, very up to date. An attack on environmental factors to bring about an adjusted equilibrium between the host and environment through ecological influences is what is interruption of transmission. So friends, this is an attack on the environmental factors, the water, the air, reduction of air pollution, noise. There should be no noise pollution. You should be immune yourself. Take multivitamins, zinc, as they say in COVID, lots of vitamin C, get plenty of rest and sleep, do exercises, do your yoga, meditation, walks, eat right, wear a mask, keep social distance. All these things are to increase your immunity, and therefore we are making changes in the overall environment. The host, that is me and you, we can get the infection from someone. The third link in the chain of transmission is the susceptible host, or people like you and me, whom we call at risk. Please remember, this is an oft repeated word, at risk. And now you must concentrate because we are coming to a very important part of this chapter. I'll repeat, the chain of transmission that is not reaching the host is achieved by immunization. Okay, it can be active, passive, combined. There should be something known to you called chemoprophylaxis, and there are certain non-specific measures. But most and the utmost importance is immunization. I've already told you about active and passive. One way of effectively controlling the spread of infection, we can also have mass immunizations. That's why we are all eagerly waiting for a vaccine in the present pandemic. Vaccination against diseases is given as a routine during infancy and early childhood. Immunization, by reducing the number of susceptibles in the community, augments herd immunity. I've talked about herd immunity before. Please recall, herd immunity is very important. It means that in case we can immunize a majority of the population, the other part, the minority, that is 20-25% who are not immunized, can achieve herd immunity, and therefore the whole population can be immune. Herd immunity makes the infection more and more difficult to spread. Every country has its own immunization schedule. We are Indians, so we will read about the Indian one. A well thought out immunization schedule is epidemiologically relevant, immunologically effective, operationally feasible, and socially acceptable. You cannot give a vaccine to a person by making him naked. Please open your clothes, I'll vaccinate you. Nobody will come to you. You will have to have socially acceptable means in the forearm, in the anterolateral aspect of the thigh. Okay, all these parts we can easily expose, but we cannot undress. Operationally feasible. I've talked about the cold chain. The cold chain should be managed and the vaccines should be reaching the consumer on time. Operationally feasible. Immunologically effective. People are showing doubts about Putin's Sputnik 5 vaccine on against COVID. They are saying that it may not be immunologically effective. So please remember, we need a vaccine which should be effective and of course epidemiologically relevant. You can't give a vaccine to me now for smallpox. Smallpox is eradicated. I can take a vaccine for the present diseases which are going to affect me. Well, Universal Immunization Program. In May 1974, WHO launched a global immunization program known as Expanded Program on Immunization, EPI, against 6 VPDs, vaccine preventable diseases. And what are the diseases? DPT, diphtheria, pertussis, tetanus, polio, TB, and measles. Exam question, we may ask you, please tell me what is EPI. The program is now renamed as Universal Child Immunization 1990 after the UNICEF said in 1985 that we must rename this program as UCI, Universal Children Immunization. Old wine in a new bottle. In India, we call the same thing as Universal Immunization Program, UIP. Exam question, short note could be part of a long question. Indian version was launched on 19th November 1985. All of you know in 1984, our previous Prime Minister, Indira Gandhi, was assassinated in October 1984. On 19th November 1985, her birthday, in memory of her birthday, that's why it is written IG, Indira Gandhi, India renamed or started its immunization program, naming it as UIP. Immunization schedules can be national, it can be WHO expanded program. That's why EPI, expanded program on immunization. National immunization schedule As per the schedule, the first visit may be made when the infant is 6 weeks old. Now, what is important here is three vaccines are given to a baby the moment it is born in the hospital. After that, only the baby and the mother are discharged. That is one of the reasons why we want institutional deliveries. Second and third visits at the interval of 1 or 2 months. OPV can be given concurrently with DPT. BCG also can be given concurrently in case it has not been given in birth, but the site of injection cannot be the same as DPT. You cannot poke needles in one muscle every time. Of course, BCG is given as subcutaneous. This schedule also covers immunization of women during pregnancy against tetanus. So these are the broad outlines. Friends, you have to just mug this up. There is no other way. You all are potential doctors. You have to know the immunization schedule by heart. At birth, BCG and BOPV 0 dose and hepatitis B birth dose. Okay, so three things are given. OPV is oral polio vaccine. BCG, we all know, is Bacillus calmette-guerin, given for TB. At 6 weeks, BOPV first dose and FIPV, fractional injectable poliovirus. Okay, that is given the first dose. Then we have rotavirus vaccine, RVV, Penta, and PCV, pneumococcal vaccine. Pentavalent contains 5 vaccines. 10
Excuse
weeks.
me, sir. Sir, your voice is very low, sir.
My voice is low. Is it okay
Yes, sir.
now? Is it okay?
No, sir, it's
Can
still
you hear
low.
me? Hello? Can you hear me now? Oral polio vaccine 2, rotavirus vaccine, and pentavalent. At 14 weeks, we have oral polio virus 3, and again, injectable polio virus 2, RVV, rotavirus vaccine, penta, and PCV. Please remember, I can't, just explain everything to you. You got to revisit and revise this table time and again so that you can remember the vaccines. At 9 to 12 months, we give MR. All these things have changed drastically over the past few years. We used to have measles, now it has become MR. MR1, JE1, vitamin A first dose. And we have a pneumococcal booster given exactly at 9 months. Now, MR and JE and vitamin A can be given anytime between 9 to 12 months, but PCV booster is given at 9 months. 16 to 24 months, we have got DPT booster 1, oral polio booster, MR2, and JE2, Japanese encephalitis 2. Now, Japanese encephalitis, PCV, they are given wherever applicable. Okay, they are not pan-India. Vitamin A dose is given, again, the second dose is given after the first dose at 9 months, second dose is given at the 16 to 24 months, this period, and then every 6 months till 5 years. Okay, now vitamin A dose in the first, this one, is 1 lakh international units. Whereas when it becomes 16 to 24 months, that vitamin A dose is just a double, 2 lakh international units. And it continues to be 2 lakhs till the time the child is 5 years. 5 to 6 years, we give a DPT booster 2. 10 to 16 years, when you become adolescents, we give TT. Now, TT is being replaced or has to be replaced by T small d, tetanus and diphtheria. That is because diphtheria is making a comeback. And even in pregnant women, TT is supposed to be replaced by TD. But friends, this is India. Whatever is there on paper is not there on the ground. I checked up, still people are getting TT. They are not getting TD. Okay? But when you write in the theory exam, write TD. The pregnant woman gets TD 2 doses at 4 weeks interval. And in case the TT, in case she has taken the 2 doses in the last 3 years, in case a pregnancy is within the next 3 years, she can only take 1 dose of TT. That's a booster. Okay? Same dosage, but it's called a booster. So this is the national immunization schedule. I wish I can stress on this time and again because it's one of my favorite topics. But then I will run short of time. New vaccines have been introduced. The FIPV, that is the fractional IPV, introduced as a part of global polio endgame strategy. and to mitigate the risk associated with TOPV to bivalent OPV. Okay, trivalent OPV to bivalent. There has been a switch about 5 years back, initially in 6 states, now all across the country. When we meet, when we revise the lessons, when you read about polio, please read about switch. RBV introduced to reduce mortality, morbidity due to rotavirus in 11 states. The vaccine was to be expanded all across the country in 1920, but I think the pandemic has stopped all these and they have taken a backseat. MR campaign, we all know, started in 2017. Telangana was one of the states. Rubella is now routine. When I took the vaccine and you took the vaccine, none of you took rubella. Rubella was taken in private, was given by some other doctor to you in a private clinic, and your parents had to pay. Now MR is a part of the routine immunization. PCV or pneumococcal pneumonia, pneumococcus vaccine was launched again around the same time, and it was launched in Bihar, Himachal Pradesh, Madhya Pradesh, some districts of UP, and some districts of Rajasthan. I already told you about TD. It is replacing TT because suddenly we have found that diphtheria is happening in older age groups, that is, adolescents and pregnant women. Now, these are certain take home points. BCG, maximum till 1 year of age, and you cannot revaccinate. Suppose a baby has come to you who's 2 years age, and she says, that the mother says that he has not taken BCG. You need not give BCG again. And there is no revaccination. If the scar does not form, there is no revaccination. So these are certain things which you need not know in detail. I can just tell you that pentavalent consists of diphtheria, pertussis, tetanus, hepatitis B, and Hib, that is Haemophilus influenzae. So these you must remember. What is pentavalent? We may ask you what is pentavalent. Well, these are all things that you should know, that there is no need to revaccinate in case of BCG. Interval between 2 doses of penta OPV hepatitis B should not be less than a month, that is 4 weeks. Minor cold cough is not a contraindication. Never send a mother or child back when she has come for vaccination in case the child is slightly unwell. You will not get the mother and child back in your clinic or OPD again. So never miss a chance of vaccinating. You are doing a favor. You are doing a big favor to the country by vaccinating a child, because you are making a healthy child. If child has diarrhea, you can give OPV and ask the mother to return in 4 weeks for the next dose. Child who has not received a single vaccine will be given 3 doses of DPT, measles 1, JE1, up to 2 years of age. You will be surprised. We are lucky people. Our parents have looked after us. They were aware. They were educated. They got us vaccinated. There are many people who are not aware or who refuse to give vaccination. In case in your practice, you get a child who's 1.5 years old and the parent says that he has not been given any vaccination, you can safely give 3 doses of DPT, 1 dose of measles, 1 dose of Japanese encephalitis in case applicable. Measles can be MR. Up to 2 years of age, you can give it safely. But please remember this table. This table is given in your book in a slightly longish form. You can take a screenshot of this, or I can share it with you later on, and you must remember this and learn from it. They are in various code words. It may be asked you in the exam, what vaccine is given from 9 to 12 months? You cannot say BCG. Many of you get nervous and you muck it up. So don't do that. Immunization is like maths. There can be only one answer. There is an IFA immunization schedule. This is Indian Academy of Pediatrics. Well, we don't follow this in community medicine because we follow the national schedule. Indian Academic of Pediatrics schedule is not the national schedule, but it is given in your book. There are various additional vaccines. I'm sure many of you may have taken them, varicella or chickenpox, hepatitis A, pneumococcal conjugate. Now pneumococcal vaccine is being a part of the national schedule. It is applicable to some states, and influenza. Many people are taking influenza vaccine during the present pandemic. They think that this vaccine or the flu shot is going to save them from COVID. I think they are wrong. Okay, but then there's no harm in taking additional vaccines if your parents can afford them. These are not free vaccines. The National Immunization Schedule, all the vaccines are free. Please guide your patients accordingly. Tell a poor chap not to go and pay a private practitioner who is taking money for the vaccines which are given by the national government, by the government free. Tell her to go to a PHC or a government hospital. There is a WHO EPI schedule also, rarely asked in the exam, should not be asked. Well, India is following that only. It was way back in 70s, 74 when it was started, but then things have been added. Okay, these are the WHO immunization schedule. You may go through it. It is given in your book. Well, we talked about passive immunization. Passive immunization, there are three types of preparations: normal, specific, and anti-serum. I have talked about all these in the previous or the previous to previous lecture when we discussed the immunity part of it. Okay? That's the hepatitis B immunoglobulin. Combined passive and active, I gave you the example of hepatitis B, I gave you the example of rabies. Both passive and active can be given in an individual. Well, chemoprophylaxis implies protection from or prevention of disease. There can be causal prophylaxis, complete prevention of infection by early elimination of invading causal agent, or there can be clinical prophylaxis, prevention of clinical symptoms, not necessarily elimination of infection. So there can be two types of prophylaxis, okay? And indications of prophylaxis are malaria, cholera, diphtheria, influenza, and all these things. Clear? So this is what is prophylaxis. Please remember, we take some drugs when we move to a potentially malarious area so that we can avoid getting the disease. That's all. Chemoprophylaxis is apprehending beforehand that if I go to a certain place, I may get this disease and therefore I can pop in a few tablets. I will give you a recent example of hydroxychloroquine, which many people started taking or they are still taking, thinking that that can prevent COVID. So in a way, you can say it is a kind of chemoprophylaxis. There are various non-specific measures, mainly the measures by the government, the legislative measures. I already covered many of them in the interruption of transmission part. So these are non-specific measures to interrupt pathways of transmission. We have already described them, but the most important non-specific measure is health education. You have to keep on educating the unaware and making them aware through media, through talks, through various other modes, through WhatsApp messages. Please make the people who are unaware aware. Health education is a chapter by itself. We will cover it later on. Surveillance, I already told you, continuous scrutiny of all aspects of occurrence and spread of disease and implementing control measures. So we are always very, very dependent on surveillance so that we can control a disease. There can be individual, local population, national surveillance, or international surveillance. So please remember, surveillance is a word which should stick with you. Health advice for travelers. Now, travel medicine is called as emporiatrics. It's a specialized branch of medicine. That branch of medicine that deals with the prevention and management of health problems of international, you can even say national travelers, because India is such a vast country that if you go from here to the northeast, the disease profile changes. If you travel from here to some other place like Rajasthan, the disease profile changes. Okay, because there are various types of climates and people all over the country. So emporiatrics is that branch of medicine that deals with the prevention and management of health problems of international travelers. Remember the definition. You may get a short note on emporiatrics. Now, there are various forms of stress when you travel, including long hours of waiting, going in an airplane, change of climate and time zones. Those of you who have traveled west to the US or the UK, you know we have to reset our watches. Then you travel in crowded spaces, in trains or planes. So these are various kinds of stress. We are also exposed to diseases which are not covered by international health regulations. Malaria, dengue, like people coming from outside, say from the west to India, they are very, very afraid of malaria or tuberculosis, because their countries don't have these diseases. So therefore, they take chemoprophylaxis or vaccines or whatever. So they are exposed to diseases to which they were hitherto not exposed. Thirdly, why is travel medicine important is because the travelers are separated from familiar and accessible source of medical care. I am familiar with Hyderabad. I know where to go. I know the hospitals. I know a few doctors. But in case you take me to some other city, I don't even know what are the medical facilities available there. I may have a health insurance, but I have to find out where are the medical facilities. If I'm alone, all the more stress. So since you are separated, you must do your homework before you travel. There is an international travel and health vaccination requirements and health advice guide by the WHO on this regard. Problems encountered during travel are motion sickness. Many of you suffer from motion sickness. When you sit in a bus which is going on a hill, you have to be very careful. You must feel pukish, and many of us take the medicines before we travel, like Stemetin. Nausea, vomiting, yawning, becoming sweaty, stressed out. Okay? Deep vein thrombosis can also happen because of travel, because you are traveling 16 hours by sitting on an airplane to the US, and you may suffer from deep vein thrombosis. You can have special problems for pregnant women, small children, the elderly, those with other problems or other diseases, those who have had a history of myocardial infarction, those people who take some medicines for lifestyle diseases. For them, you can have special problems. Age, I told you already. People who are too young or too old may have some problem. Pregnancy, okay, there are various things written about this. Let's not go into too much of details. Heart disease, we all know, in case you have a pacemaker and in case you have other problems, you will have some problem in traveling and you have to carry your medicines, also take a special seat and all these things. Chronic lung diseases, very, very important in COVID times. Diabetes mellitus, water. When you travel to a new place, for us, it may be okay if we travel to a developed country, but for the person coming from a developed to a developing country, the water may be quite, difficult to drink because they know that water is polluted in countries like ours. Food, boil it, cook it, peel it, or forget it. Please remember, all raw food is subject to contamination, so you got to have properly cooked and rightly cooked food when you are traveling. Vaccinations, there are various vaccinations that you can take. It's up to you, but the most important is yellow fever vaccine, which is required for international health regulations, international health travel to certain countries in sub-Saharan Africa and tropical South America. Those countries are marked in red. In case you are traveling to countries like Namibia or Ethiopia, you will have to take a yellow fever vaccine. The only vaccine required for international travelers, which is compulsory, is yellow fever vaccine. Please remember that. This is an exam question. It's a Viva question. Well, people who travel to Saudi Arabia for Hajj, they will have to take meningococcal vaccine. But then if you are traveling to some other country, this is not compulsory. So the only vaccine which the WHO stresses on is yellow fever vaccine. Of course, you can also mention if in Viva we ask you what else. You can also say meningococcal vaccine. Well, people have travelers diarrhea. Many a time we have traveled, we have eaten proper food, homemade food, but when we have reached the new place, we have got diarrhea. TD or traveler's diarrhea is a very, very common condition marked by increasing frequency of unformed bowel movements and is commonly accompanied by abdominal cramps, urgency, nausea, bloating, vomiting, fever, and malaise. Please remember this. And each of these have to be treated. So all these treatments and all, I'm not going. Hepatitis, be very careful. Many of us have suffered from jaundice when we were small or when we were young. Hepatitis A or E is very common and is acquired through water or food contaminated with human feces. I already told you about the sanitary barrier. Please remember that. Avoid ice, avoid unpasteurized milk, avoid unpasteurized dairy products, avoid food from street vendors, wash hands, all these things your parents keep on telling you. Write whatever comes to your mind in case you get a question on this. Malaria, I already told you about the chemoprophylaxis part. There are primary, causal, suppressive, and terminal prophylaxis in case of malaria. Basically, they involve the use of various anti-malarial drugs. In primary prophylaxis, we use a certain drug. In causal prophylaxis, we use some other drugs like primaquine or proguanil. In suppressive, we use chloroquine, proguanil, meflo, or doxy. And in terminal prophylaxis, we use some other drugs. So don't have to go into so much of details, but remember, we have to start the dosage 2 to 20 days before departure to a malarious area. And you have to continue taking the drug for a duration of a week or so, or maybe a month after return. So if you want to remember, 14 days before start, 2 weeks before the start, we must start taking the drug, and say about 2 weeks to 4 weeks after return, we must continue the drug. While staying in the area, we should continue the drug. Prophylaxis is you assume that I may get this malaria if I travel to Assam, if I travel to Tripura, if I travel to some other state, I may get malaria because our place is basically malaria free, but those areas, they are very, very malarious. Tetanus, not seen nowadays, but again mentioned in travel medicine. Rabies, there are certain countries which are free of rabies, but India, there are many stray dogs. Foreigners traveling here need to be very careful because there are stray dogs which may get excited and may bite. HIV, very important, and we all know the preventive measures. Bird flu, SARS, and COVID are the other important diseases which can be added. Well, all of you must be following this, or you must be knowing this, that when we travel to a certain place, we need to carry our own first aid kits and our medicines. And what all should be there in this first aid kit is listed out here in this slide. So you can just carry some eye drops, some insect repellent like Odomos, some simple analgesics, some sterile dressing, adhesive tape in case you get a cut, some band-aids. Okay, all these things you can carry in a small box, and that can be your first aid kit during travel. And evaluation, contingency planning, and we all should remember the 6 I's: insects, ingestions, indiscretion, injuries, immersion, and insurance. Anyway, don't have to remember all these I's and all that. They're not very important. What you can get in the Viva and in the exam as a short note is emporiatrics. Please don't get baffled by the term. All it means is travel medicine. And we all are traveling, we all have traveled, we all know what kind of precautions to take, which are the diseases which can happen. And the most important part is that the only vaccine which is required for an international vaccine certificate is the yellow fever vaccine, nothing else. Once you take a yellow fever shot, it is valid for lifetime. Initially, it used to be 10 years, now it is lifetime. In the investigation of an epidemic, we just described what is a epidemic. It's the unusual occurrence in a community of health-specific behavior or events, clearly in excess of expected occurrence. Okay, we know what is an epidemic, and there are 10 steps in the epidemic investigation. Please read them up from the book. They are given in short paragraphs. The first part is to verify the diagnosis. Is somebody spreading a rumor? There are so many cases of malaria in this village. So many people have died because of cholera in so and so area. Is there a rumor? So you have to verify the diagnosis. And how do you do that? By clinical examination of a sample of cases and by lab investigation, by going to the spot. See, that's where a community medicine specialist is important. He works in the community. He goes to the spot. He doesn't sit on a chair and wait for the people to come, just like in a hospital. Then we have to confirm the existence of an epidemic. You have to go to the previous data and find out that the cases this year are clearly in excess. So you declare that there is an epidemic. So that's the second step. Third step is defining the population at risk. You should obtain a map of the area and you should have a population count. What is the population at risk? There are 20 cases in a village. So you know the whole village and the villages surrounding that village are the people who are population at risk. I'm just telling you in a very quick and a simple manner. You can just go through your book, underline a couple of important things. If the question comes in the exam, don't write paragraphs under each point. Write a couple of important and relevant lines. Then you have to do a rapid search. See, in the initial part, when you verify the diagnosis, you had just a few, odd people. But now you have a possibility of getting more number of cases. So you do a rapid search by a survey, and you fill up the data in a case sheet, which is called as an epidemiological case sheet. And you search for more cases. How do you do that? You can't do it alone. You have to do it with your team. So it requires a team. Okay, rapid search is the fourth point. Then we have data analysis. You have collected the data, you will analyze the data. Those of you who have done an ICMR project, I keep repeating that, would have gone through these steps. You analyze the data and you make an epidemic curve. I told you about an epidemic curve when I taught you about the terminology of epidemic in the descriptive epidemiology part in the beginning of the lesson. Please remember that. So epidemic part, epidemic curve, then you formulate a hypothesis. On the basis of time, place, and person, you have to formulate a kind of hypothesis. What is the possible source? What are the causative agents? What are the possible modes of spread? And what are the environmental factors which enable this disease to occur? So as an epidemiologist, you have a lot to do, and you are a very important man or woman. Okay? Then you test the hypothesis. Whatever hypothesis you wrote down, is it right? Will it be okay in case I give it to the higher ups? All reasonable hypotheses need to be considered and weighed by comparing attack rates in various groups for exposed and non-exposed. By this time, you know the case control studies. Evaluation of the environmental or the ecological factors. Never, ever disrespect the environment around you. Today, we are getting the new diseases because we have disrespected God's nature, and we are getting diseases like HIV and COVID. Always look after the water, the air, the soil around you. And these are the various factors that need to be evaluated. There can be a water milk supply chain which is disrupted. There can be some migration which has happened and caused this disease. So all these things are the evaluation of ecological factors. You can do some further investigations. You can carry a lab person with you, do some investigations, do some epidemiological studies to further, establish that we have an outbreak and it is because of this. And finally, you have to write a report. The report writing, as I keep telling, those of you who have written a ICMR report will know that there are various steps in writing a report, starting from background or introduction to historical data, the method you adopted for investigation, analysis, and the control measures that you suggest to be implemented or you implemented. So please remember, this completes the chapter on epidemiology. Because of some technical glitches, I ran a little overtime. Disinfection and sterilization we have already covered in the class on clinical posting, and I will not have time to cover this or maybe repeat it in the next class. No, I won't have. There are various agents, there are definitions, and there are recommended procedures of disinfection. You can just go through them in your book. They are easy. Underline one or two important lines and keep them up your sleeve for the answers. To repeat, we finished the chapter on epidemiology. Today, we talked about the interruption of transmission and disease prevention by attacking the reservoir, the intermediate transmission part, the environment, and the susceptible host. Then we also talked about travel medicine, that is emporiatrics, and we rounded off with the 10 points of epidemic investigation or investigations of an epidemic. Thank you very much. Please revise. All the best. Stay safe.